The last presentation of this cycle, we are going to speak about major neurocognitive disorders, or dementias, how it used to be called in the past. And I think that they will continue to be called this way for a long period of time. So we start, as usual, with a review of what we did last time. We talked about ADHD. We talked about the epidemiology of ADHD, and as you remember, this phenomenon called ADHD is really pretty frequent. It's actually more frequent than bipolar disorder, which is has a prevalence, 12 months prevalence of 1.1, more prevalent than schizophrenia, a prevalence of 1.3, even more prevalent than major depressive disorder, which has a prevalence, 12 months prevalence of 5.6. ADHD has a prevalence in as of 2020 of 8.9%, so it's pretty high up there. We talked about the definition of ADHD according to the DSM-5, and we were noticing that it's a complicated, dense diagnosis. It has two components, the inattention and the hyperactivity. The cluster is composed, the symptomatic cluster is composed of 9 symptoms, and 6 out of 9 must be fulfilled. Surprisingly, there are actually quite a bit of varieties in which 6 out of 9 conditions can be met. We were speaking about the manic episode, for example, having for about 30 something varieties in which it can present itself. The substance use disorder had 77 varieties, but actually ADHD has about over 100 ways in which it can present itself. But despite the fact that there are much more combinations in the diagnosis of ADHD, the likelihood of hitting 6 out of 9 criteria is far less likely than hitting 2 out of 11 criteria. And also the look back period, the period of interest, is actually much more generous in substance use disorder, 12 months, a year, while in ADHD the period of interest is actually 6 months. So it's a complicated diagnosis, but also very frequently encountered. So despite the fact that this has a lot of criteria to be met, the prevalence is pretty high up there. We talked about the pathophysiology, and we saw a very nice biological gradient or genetic gradient. That means we saw that people who, twins who are monozygotic have a concordance rate of 60 to 90%. The dizygotic twins have a concordance rate of around 52%, and the siblings have a concordance rate, non-twin siblings have a concordance rate of 50%. So it's not surprising that it's very close to the dizygotic twins, because the dizygotic twins are actually very similar to regular twins. They have a different set of genetic material. And then it drops down to 8% into half siblings. That means children who have only one parent in common. So you see, the longer you are, the more remote you are from the genetic configuration of an ADD patient, the less likely you are to get the illness. So it's a biological or genetic gradient that very nicely prove that the heritability index of this ADD is actually very high, is around 0.9. Do not forget, heritability index is the genetic variance divided by phenotypic variance. So when a person, or when an illness has a heritability index of 1, means that that illness has only a genetic component, and the environment plays no role. As a comparison, the heritability index for bipolar disorder is around 0.8, and the heritability index of schizophrenia is also around 0.8, 0.9. So these are 3 illnesses: bipolar, schizophrenia, and ADD, with a strong genetic component. Then we talked about the pathophysiology, the pharmacological treatment was supposed to be discussed, but we didn't end up discussing because we got sidetracked in that almost philosophical debate about whether we should treat people with ADD who otherwise function satisfactory. But I just want to mention this because it's, in my opinion, too important for the day-to-day practice, and I'm going to mention the issue of the treatment. Now, in ADD, the treatment is done predominantly with medication. There is a psychosocial treatment defined in books, you can look it up, but it's pretty minor compared with the power of the pharmacological treatment. And the pharmacological treatment contains 4 classes of medications. One of them is the stimulants, the SNRI, that means selective norepinephrine reuptake inhibitors, the alpha-2 stimulants, and the alertness promoters, modafinil and armodafinil. The stimulants essentially are of 2 varieties, MPH, methylphenidate group, and the amphetamine group. I did put there also the pemolin group, but that is more of a historical interest. It's a defunct medication, and it died a dishonorable death in the sense that it was withdrawn from the market because there were some instances of acute liver failure. That's what I call the dishonorable death, because there's an honorable death, and this is a medication that stops being produced because the public loses interest in it and is no longer prescribed. And there are medications, to some tricyclic antidepressants, for example, maprotilene, who was practically sidetracked, not because of any fault of its own. It is still a good medication, but it was just no longer economically feasible to produce that medication, maprotilene. So the selective norepinephrine reuptake inhibitors are equally in efficacy to the stimulants. There have been head-to-head studies compared the two, and it seems that they perform the same. But the stimulants are far more popular than SNRIs. And why? I do suspect that this has something to do with their power of stimulating the reward system of the brain, like any other drug of abuse. So aside from correcting problems with attention, they also seem to give people some kind of pleasant feeling. And this, I am sure, accounts for their popularity. And also the fact that they act right away. You don't have to wait. While for the SNRI, you have to wait for 4 to 6 weeks until you see the maximum effect of a certain medication at a certain dose. You have to always make sure that the patient understands that. It doesn't mean that there is no effect until 4 to 6 weeks pass by. It just means that the maximum effect will peak after 4 to 6 weeks. I like to use the number 6 plus minus 2 weeks. That means at least 4, maximum 8 weeks of treatment are necessary before you can make a judgment about what that medication did. So there are 2 varieties of these SNRIs. In the past, for a long period of time, was only 1, but recently, for about I would say less than a year ago, viloxazine came on the market under the name of Qelbree. Also in the SNRI category can be included the TCA, the tricyclic antidepressants, desipramine and nortriptyline, which are predominantly serotonin enhancers, and bupropion, which is the TCAs are predominantly norepinephrine enhancers, desipramine and nortriptyline. Bupropion is also a predominantly norepinephrine enhancer, but it also affects the dopamine system, enhancing the transmission of dopamine by blocking the reabsorption of dopamine. The alpha-2 stimulants are very interesting because you see, the norepinephrine stimulation will result in improvement in attention, but alpha-2 stimulants are doing actually the opposite. They tone down the activity in the sympathetic system, in the central sympathetic system, by stimulating the alpha-2 receptors. Alpha-2 receptors are actually autoreceptors. So if you stimulate the alpha-2 receptors, you are actually inhibiting the release of catecholamine. So that's why the alpha-2 stimulants actually end up inhibiting the tonus of the sympathetic system, and therefore diminishing the hyperactivity that you see in ADHD. There are two of them, centrally acting alpha-2 stimulants, guanfacine and clonidine, used in the treatment of ADHD, but predominantly for the hyperactivity component. And the alertness promoter, kind of very colorful situation. Modafinil or modafinil, they perform in studies as good as the stimulants, but they would never got the approval. They actually had the approval request. And while this was going on, the FDA was looking at the approval, at the claim of efficacy in ADHD of the manufacturer. Some cases of Stevens-Johnson syndrome showed up, and therefore the manufacturer itself withdrew the request. But it remains a fact that modafinil and armodafinil are effective in adult ADHD. And this thing with Stevens-Johnson syndrome happened actually in children and adolescents. Well, I'm not very sure what was the age of these incidents of Stevens-Johnson syndrome, but they were not adults. So still kind of a good option to have. Then let's go to the stimulants, which are by far the most popular medication group in the term of ADD. So there are two big groups, the methylphenidate group and the amphetamine group. Again, all of the others are actually variations on the same theme. So the methylphenidate group has the methylphenidate proper and dexmethylphenidate. And on the other side, the Adderall has the amphetamines have the amphetamines mixed salts. There is no amphetamine, pure amphetamine. There is the amphetamine mixed salts, or dextroamphetamine, which is the dextroisomer of the amphetamine substance, a substance which is a 50-50 racemic mixture of two optic isomers, right side and left side isomer. As you see, the products themselves are actually variations. I mean, what do you do with these substances? You kind of make it in such a way that they are longer acting than the original compound. Make a product that can be taken by chewing the tablet instead of swallowing it. Make a product that is liquid for kids who might not like to swallow pills, and make eventually a product that can be administered as a patch, like the case is with Daytrana. It's a methylphenidate product. And on the other side, do not forget, out of this list, and by the way, the ones with a red star are products that did go through the approval process with the FDA to be approved for adults. So this is one of the very few instances in psychiatry where the medications that we have for children and adolescents is more numerous than the medications that we have for adults. Usually is the other way around by a wide margin. If you look at the antidepressants, for example, out of 26 antidepressants, only 2 are approved for children and adolescents, and these are Lexapro and Prozac. When it comes to stimulants, you see the situation is actually the reverse. Most of them are approved. I mean, all of them that you see on the chart are approved for children and adolescents. So that's where the initial release on the market starts. And then if they have economic interest, some of these products, they will pursue the FDA approval for adults as well. You are very safe to use any product in adult, because there is no way that you can harm an adult with a product that is okay for children. I do not know of any example where a medication which gets approval for children and adolescents can be a problem for an adult. So, but anyway, it's let me draw your attention on the amphetamine salts. The amphetamine mixed salts actually means a mixture of 4 salts: amphetamine sulfate and the dextroamphetamine sulfate, plus amphetamine saccharate and dextroamphetamine aspartate. So these are 4 different salts which are in the same mixture, and they are marketed under the name of Adderall. Adderall is by far the most famous name in among stimulants, and the most likely to be misused. By the way, I usually, when I have concerns about misuse, I just stay away from very, how do you call it, well-known brands. For example, I stay away from Xanax when it comes to benzodiazepines, and I stay away from Adderall. And not because these products are more addictive than the other members of the group, but just because they have a brand recognition, and therefore they are most prone for all sorts of mishaps. Some of them kind of sneaky behavior by the patients, but unfortunately, it's a big deal of misappropriation of the medication if anybody else stumbles upon them. Because who heard of, let's say, Zenzedi? If you see Zenzedi on a label, you are not going to know what to do with it. But if you see, or Procentra, you are not going to know what the hell is that. You are going to leave it alone. But if you see Adderall, if you are a drug addict, you are going to misappropriate it in a second. So let's go to the main topic for today: dementia, or major neurocognitive impairment. How is it called more recently? We are going to talk about the history, the definition, according to the DSM-5, of course, varieties. We are going to focus on Alzheimer. How did I get misspelled in there? I don't know. But anyway, Alzheimer. And then we are going to talk about comorbidity. When it comes to dementia, comorbidity is a little different, in the sense that it doesn't mean that you have parallel diseases, are just symptoms that can appear in the course of dementia, but they're not standalone, separate illnesses. And we are going to talk about the treatment as well. So let's see about the history of this problem. The history starts with Celsus Aulus, or Aurelius. Some people call it Aurelius. Aulus Celsus, a encyclopedist, I would say, because nobody knows. It's a very mysterious person. Nobody knows if he ever practiced medicine, actually. But he wrote a famous treatise of medicine called De Medicina. He lived under Caesar Augustus, the emperor of the Roman Empire, and that's all we have about him. We don't even know where he lived. That might be in Rome, or it might be as far as in Gaul at that time. Anyway, he was the first one who saw this interesting phenomenon of older people losing their mind, and he named that problem dementia. Well, he named it dementatus, and dementatus in Latin means out of one's mind. It's a name that it's probably suitable for any psychiatric illness. But he was the first one to take notice that this phenomenon is happening with elderly people. Then Oribasius, who was the personal doctor of Julian. Julian was the last emperor, the last non-Christian emperor of the Roman Empire. Actually, at that time was already the Byzantine Empire. And by the way, he was also called by the Christians Julian the Apostate, because he was the last non-Christian emperor of Rome. Actually, very interesting character. Big admirer of Marcus Aurelius, which is pretty much the prototypical philosopher king. And that means a king who was quite a notable philosopher as well. He was a adept. He was a how to call it, a fan of the Stoic philosophy invented by, or let's say founded by Zeno in Athens. And it has to do something with accepting everything that life throws at you without blinking an eye, taking good things and bad things with some sorts of equanimity. Very good kind of frame of mind actually for a psychiatrist to be in all the time. So no, don't get too excited or too distraught about anything. That's the best emotional range in which a psychiatrist should be. Too much of enthusiasm is going to make you less empathic, and too much pessimism and too much anxiety is going to make you unable to help someone, to drag someone out of a negative emotional state. But anyway, Oribasius was the one who actually made a connection between the dementia and the shrinking of the brain. So he was the first one who made that observation. Then the next notable contribution to dementia is Jean-Étienne Esquirol. Jean-Étienne Esquirol, a psychiatrist, a French psychiatrist, he was the one who noticed that dementia is not just about losing the memory. It's very often accompanied with some other malfunctions of the mind. So he was the one who noted that part of this illness can be delusions, hallucinations, and also of affective problems. Then Kraepelin, another important figure, Kraepelin made a distinction between dementia that happens in old age and so-called dementia that happens in younger people, but a little bit of a problem. He called it dementia precox as opposed to senile dementia. But actually, this dementia precox, it was actually schizophrenia, so it was nothing to do with dementia, nothing pathologically similar with dementia. Then we have Alzheimer, who practically defined the illness, going down to histopathological causes, and he, for a good cause, now lent his name to this illness. Actually, very interesting, Alzheimer was a pretty modest doctor. He did not call the senile dementia Alzheimer dementia. It was Kraepelin who was only marginally involved with dementia, but he saw what Alzheimer did for his contribution to the definition of this illness, and therefore Kraepelin decided to name it in the honor of his colleague. They knew each other, his colleague Alzheimer, to call senile dementia Alzheimer dementia. Well, so let's see the epidemiology. The epidemiology is interesting because it starts very modest at 1.9%, so pretty low percentage, but this only in the 65 to 70 age group. Then it goes, then it starts doubling every 5 years. And by the time people are in their 85 to 90 period, the prevalence is 21.7%. But it's even worse in primary care settings. The prevalence goes much higher, and in nursing homes, doesn't matter who you find, and is no consideration of age group. If you go in the nursing home, probability is that 60% of the people there will have dementia of some type. Let's dismantle the diagnosis now. You will be surprised, but the DSM-5 does not, put weight on memory loss when they define dementia. And also a very interesting structure of this diagnosis, it almost has no clustering of any kind. Doesn't have symptomatic clustering, doesn't have a temporal clustering. They don't mention anything about it. They have only conditions, sine qua non conditions. So, I mean, you can argue that what you see in the upper part of the slide is a symptomatic clustering. That means you have to have one of these 6 areas impaired in order to call it dementia. But actually, they are arranged in such a way that it is more suggestive that these are sine qua non conditions. Are they exclusions or inclusions? So the inclusions, there must be a impairment in any of these functions. It doesn't have to be more than one. Often it is more than one, but it can be at least one. And these are learning and memory, language, complex attention, executive functioning, perceptual motor ability, social cognition. Now, these impairments have to be noticed by self, that means by the patient, or by others. They have to represent decline from the previous baseline, because if the patient is very smart, then it's going to take a while until they see a difference compared with their peers. So you have to somehow judge the decline according to what was the premorbid functioning of that patient. They cannot be present only during delirium and other psychiatric illnesses. That means that's an exclusion sine qua non criteria. And then it must interfere with the ADLs, and it must be documented with neuropsychiatric testing or clinical test that you do in a regular interview, like MOCA or MOCA testing, or mini mental status. So you have to have some kind of objective rating scale to demonstrate, to be able to use this diagnosis of dementia or major neurocognitive disorder. Dementia, you will be surprised how vast this diagnosis is. We in psychiatry, we are dealing mostly with the neurodegenerative dementias, but there is also a vascular dementia, and the vascular dementia can be also of a variety of types. Actually, anything that impairs the flow of blood to the tissue of the brain can cause dementia. Either an impairment caused by Binswanger disease, and the Binswanger disease is an arteriolosclerosis. That means a problem that involves the small vessels that go inside the white matter of the brain can be damaged by arteriolosclerosis and choke the blood supply to the brain tissue. But also it can be something more major. For example, an obstruction of a bigger blood vessel, like in a cerebrovascular accident, either hemorrhagic or a thrombotic event. But and of course the hemorrhagic will have kind of much bigger consequences than an obstructive cerebrovascular accident. And of course there is also something that can happen at a distance, so it has nothing to do with blood vessels inside the cranium, inside the skull. It can happen, for example, on the carotid artery. So the stenosis of the carotid artery can lead to vascular dementia. Another type is the neurological. Now you might say, what's the difference between neurodegenerative and neurological? Well, neurodegenerative means that there's a problem with the neuron itself. The neurological is something else, like a brain tumor or NPH or MS. And normal pressure hydrocephalus, and MS is multiple sclerosis. And you might say, hey, wait a minute, but multiple sclerosis, that's what it is, a degeneration of the neuron. Actually, no. Multiple sclerosis is a degeneration of the Schwann cells. The myelin surrounding of the axon, the tunic of the axon, is the one who is affected in multiple sclerosis, not the neuron itself. So it's that's why it's placed into the neurological. Then endocrine, hypothyroidism, hyperparathyroidism. Don't forget, hyperparathyroidism is will lead to excessive calcium concentrations in the bloodstream, and this has a paralyzing effect of the neuron, which eventually starts dying because of too much calcium in their environment. That's therefore is an endocrine cause of dementia. Then insulinoma, obviously, if you choke the glucose that the neuron needs to function properly, and that's what the insulinoma does. When insulinoma increases the production of insulin, therefore the blood sugar stays chronically low, and this will impair the functioning of the neurons in mass, and can cause dementia. Then a nutritional, the famous vitamin B12 deficit, and the lesser famed vitamin B1 and B3. B1 or thiamine is particularly deficient in chronic use of alcohol, and dementia that is caused by the deficit of vitamin B1 or thiamine in chronic alcohol use is called also Korsakoff dementia. It's a particular kind of dementia because it comes with confabulation. That means people filling the gaps of the memory with how do you call it, imagined content. There is in Dostoevsky, actually, in The Idiot, in the novel called The Idiot by Dostoevsky, a very nice representation of Korsakoff dementia. One of the older characters in that novel was describing how he was traveling in a train, and two very obnoxious women were standing in front of him, and he wanted to smoke, and they objected to his smoking, and then he said, "Well, I am also bothered by your dog," and he grabbed the lap dog and threw it out of the window. And this he presented as if something that happened to him and he was the character, but actually one of the listeners say, "Hey, wait a minute! I think I read this into a French magazine. I think that that was happening actually in France." And the man was continuing to say, "No, that was me, and everybody knew that he was again confabulating. So then it is a traumatic dementia pugilistica. That's got a little bit of fame, not a little bit, quite a bit of fame with the football helmet, the scandal. That's a very real thing. Actually, I had a gentleman who was I had a patient who was a professional football player, and he developed dementia. And it's hard to say, but people kind of suspected that it had to do with his career in football. Then there is the metabolic dementia. Wilson disease is a thesaurismosis. That's how we call it in Romania, at least. Thesaurismosis. That means the inability of the body to get rid of copper, which is starts accumulating in all sorts of organs, in the liver especially, but also in the brain, and it can cause dementia. Then infectious causes, neurosyphilis is a classic. We call it, well, we used to call it again, kind of in the good old days of medicine, the great imitator, because it can really present itself in such a variety of ways, and they will trick you into believing that the patient is suffering of schizophrenia or of dementia, and actually they had neurosyphilis. And of course the famous HIV dementia, which probably still has quite a bit of relevance, because HIV now is a chronic illness that you will run into. Then it's the toxic, and among the toxic dementia is really the heavy metals, mercury, sorry, the lead poisoning, which is very useful for you to keep in mind when you try to distinguish. But the lead poisoning appears in younger individuals. So usually the kids who are exposed to paint, lead-based paint, which of course now is outlawed. But that was a typical presentation in a child or adolescent who seems to have symptoms of dementia, and you're scratching your head and wondering why. Well, exposure to some heavy metals, mercury, but more classic lead can be the cause. And the radiation dementia in people who have cancer treatment. So the neurodegenerative dementia, that's a bread and butter of psychiatry, and is kind of a area contested by neurology as well, is the good old Alzheimer dementia, but also dementia with Lewy body, the Parkinson disease dementia. Do not forget dementia with Lewy body and Parkinson dementia are pretty much the same. The PDD, we called Parkinson's disease dementia, the kind of dementia that comes with an onset of Parkinson's symptoms, and also the Parkinson symptoms, motoric symptoms, are predominant, and dementia is kind of secondary. And the dementia with Lewy body is the other way around. The dementing symptoms are first, and the Parkinson the motoric symptoms are kind of a secondary appearance, a secondary importance. Now, the frontotemporal dementia, which has each own subtypes. Then we have the Huntington's dementia, the corticobasal syndrome, another form of dementia, and then the progressive supranuclear palsy. And that's kind of another variety of dementia, which its characteristics and its pathological story. And the prion disease. Prion disease is really something that is kind of colorful, I would say. The prion disease was discovered by Dr. Gajdusek. Gajdusek sounds Slovak or Czech, but in reality he was born in Midwest. So Dr. Gajdusek went to Papua New Guinea to study a mysterious disease that affected the cannibal tribes that was called Kuru in Papua New Guinea. And he started looking for these people, but it was a nightmare to locate these people because it was affecting adults or young adults. And when you get a member of the family who developed this kind of dementia, he's going to be a shame for the tribe, and he's going to be stuck in a hut. Nobody wants to talk about this person. And anyway, they had to discover these patients, convince them to give blood, and this all in a tropical climate with a very hot and humid temperature all the time. And then imagine what a complication to get the brain of these patients who die of the disease called Kuru. At one point, they kind of did it in a sneaky way, and that means getting the brain in the hut. That's where an anatomopathologist came with Gajdusek and dissected the brain in the hut where this patient died. And when the tribe found out what they were doing, they were kind of out to kill them, and they had to run out of there, barely escaping with their lives. But anyway, Gajdusek, and then like how do you discover what causes this illness? Because it's not actually the typical pathogen like a germ or a fungus or a virus. It's actually a protein. And the protein, you can imagine the virus is composed of hundreds or maybe thousands of proteins. And the cause of prion disease is actually a protein. Gajdusek actually got the Nobel Prize, and I think that for his efforts, he really deserved it. But his fame lost quite a bit of luster when it was discovered that the young Papuans who brought with him from Papua New Guinea was actually his harem. So he was molesting these young Papuans. And obviously, in the face of the law, doesn't really matter if you are Papuan or any other nationality. You molest kids, you are going to go to jail. And that's what happened to him. So he's a Nobel Prize winner who ended up jailed for child sexual abuse. Very, very colorful and interesting story. So let's move on. How did we get from this to this? And the first one is a photo taken in West Riding Lunatic Asylum in UK in 1869. And you might say, "Oh, come on, that's a how do you call it? Electric chair." No, there's not an electric chair. Actually, the punishment, the death sentence through electrocution started with Thomas Edison in 1890. So this photo is 1869, and the electrocution started in 1890 with Edison. And I think Edison was inspired maybe from this crazy restraint mechanism. So this is actually a patient who, a violent patient or a rowdy patient was immobilized in this chair. And obviously on the right side is TMS. So, well, the medicine was actually in the medieval times based on gut feelings and hunches, so completely non-scientific. The scientific revolution started towards the end of 19th century and the 20th century, when science was injected into this specialty massively. And we see the same evolution in psychiatry. Psychiatry lagged quite a bit behind to the rest of medicine. They became science penetrating into psychiatry much later. So let's see now the core of the issue. So these are things that were discovered by Alzheimer, the plaque, beta amyloid plaques, and the neurofibrillary tangles, which are tau proteins. So the story of what we call today Alzheimer start with two characters, Auguste Deter and Aloysius Alzheimer. So Auguste Deter was a 50-year-old woman who was brought by her husband to the hospital because she was accusing him of infidelity. And this man was a working class person, railroad worker. And of course, besides that, he was becoming kind of a management problem because her memory was fading. She was completely useless. So on the contrary, she was a burden for the family. So brought her to the Institution for Mentally Ill and Epileptics in Frankfurt. And they run into Aloysius Alzheimer, who was a doctor there, 46-year-old. And it was an encounter that actually changed his life. So Aloysius Alzheimer probably would have died an unknown person, but because of meeting Auguste Deter, who he took an interest in, his legacy was changed forever. So he took an interest in this woman. At the age of 55, Auguste Deter died, and by that time, Aloysius Alzheimer was already moved to the Royal Psychiatric Clinic in Munich. He made arrangements to get the brain sent to him, and together with Dr. Franz Nissl of Nissl body fame, he discovered the histopathological underpinnings of this illness. And I would say that arguably Alzheimer is the most famous name in psychiatry. Freud is also kind of famous, but his fame is actually in decline because Freud was not using scientific method. He was more of a poet or literary or a combination of scientist and writer. But anyway, Alzheimer did something that stood the test of time. The illness, senile dementia, is called nowadays almost by everybody Alzheimer. Now, this illness is caused by the accumulation of the amyloid plaques. The amyloid is this molecule, nice molecule that you see here. It's actually the beta amyloid. It's coming from the amyloid precursor protein. Amyloid precursor protein is actually a functional protein, a glycoprotein that is floating in the membrane of the cell. And when it's at the end of its life, it's dismantled. Is cleaved by an enzyme called secretase. The enzyme secretase is actually of several kinds. One of them is alpha, the other one is beta and gamma varieties. Alpha secretase splits this molecule into soluble components, and that is not going to be any problem. But the beta and gamma secretase will split it into beta amyloid, and beta amyloid is not soluble, and it must be disposed of. And the disposition is taken care of by the protein called apolipoprotein E. The apolipoprotein E takes this molecule by the hand and throws it into the lion's cage. That means into the lysosome, where it's dismantled to smaller pieces that can be reused for metabolic processes. So when this apolipoprotein E has a blueprint in the genetic code, and the gene that produces the apolipoprotein E is called, guess what it's called, is apolipoprotein E epsilon. So apo-epsilon is the name of the gene. And this gene has 4 varieties or 4 alleles, 1, 2, 3, 4. And 1, 2, 3 are okay. The apo-epsilon 4 is the trouble. If you have 2 of these genes, then you are going to have a 50% increase of risk of developing Alzheimer. So it's used as a marker for Alzheimer. So, but that's not the end of the story, because first of all, it's only 50%. What happened with the 50? Why don't they develop the illness? It's not really that impressive, 50. So it must play a role. But then there's another trouble with this theory. The African population has a higher frequency of homozygote APO epsilon 4 than the white population, but has less dementia than the white population. So that's kind of still suggesting that it's not the end of the story. So this is beta amyloid, and this one here, this molecule is the tau protein. Tau protein are the building blocks of the cytoskeleton of the microtubules of the neuron, and these tau proteins also have a problem. We don't know what is the problem, but they are not properly disposed of, and they accumulate in the neuron. So these two accumulation of beta amyloid and a tau protein will lead to impairment of the cell that is going to end up with the death of the neuron. Now for the detractors of psychiatry who are saying, show me the lab, show me something palpable, that your constructs are actually real scientific. Well, this is a nice example where the Alzheimer can actually be shown in a very nice, prominent way to cause some changes in the brain. This is a PET scan using F18 fluorine 18 radioisotope. So it's an isotope of fluorine that is radioactive, and it's incorporated into three products: fluor beta ben, fluor beta pir, and flutemetamol. And these three radio tracers can be injected in the bloodstream, and they latch onto the plaques or beta amyloid plaques, and they make the brain light up like a Christmas tree. As you see here on the left is a normal brain, doesn't really fluorine isotope 18 doesn't have much to, I mean, these substances actually latch on, not the fluorine, the atom. The atom is in the mix of the products, flutemetamol or fluor beta pir. So the fluoride ion is actually a isotope, a radioactive isotope, and latches onto the plaques and makes them light up. And on the right side, you see in severe Alzheimer how the brain changes in a very prominent way. So we are going to skip that part to how to diagnose it, and we're going to go to this concept of comorbidity. Aside from the cognitive problems, there are also symptoms that are suggestive of depression, anxiety, mania. Psychotic symptoms are pretty prominent. That means delusions are very common, hallucinations sometimes. Agitation can be with or without any disturbances, emotional or cognitive. If you do diagnose the dementia, you first of all have to confirm that it's an Alzheimer dementia. Then you introduce the treatment. And the treatment for Alzheimer is going to be the centrally acting cholinesterase inhibitors, because the memory neurons are using the acetylcholine as a neuromediator. And if you protect this neuron by inhibiting the enzyme that destroys the neuromediator, acetylcholine, that means the acetylcholinesterase inhibitor, then you're going to have more of acetylcholine floating around, and in general, this machine of the memory will work better. And then, of course, there is also the memantine or the smart zinc. The zinc has a role in preventing the excessive excitation of the neuron. It's a little bit like it prevents the neurons from being over-solicited. And if you do so, then you are going to have a neuron that will break down, will just die. And a little bit of a story with a neuroleptic. When you have psychotic symptoms, you can't avoid neuroleptics. Neuroleptics that did prove to have a 1.6 to 1.7 fold increase in mortality rate, but there is no way to avoid them. If psychotic symptoms are present, you're not going to address that with any other group of medication, but you have to make sure that you get the informed consent from the family members. And the patient too, but only the patient is not going to be enough. You have to get someone who is legally responsible for the patient to say yes, to be safe from litigation. So these are this is the end of the last one. So I guess we will probably meet again in the next cycle. I don't know if you are going to be there in or September and October. So I hope the next presenter is someone around. Okay, so I am going to turn you over to the next presenter. I hope that he's somewhere nearby, and do not forget, any questions, just ask Patty. I guess she will know how to get in touch with me, and I hope that this one will be recorded and also made available for anybody else who would like to see it. Okay, see you soon.
Thank you.
Bye. Thank you.